Welcome to another EduMed video, and in this video we continue our review of the Surviving Sepsis COVID-19 guidelines, and we specifically focus on the ventilatory support section of the guidelines. The Surviving Sepsis campaign have created this guideline, which is only recently been published at the end of April. It hasn't made itself into print yet, and so you can get it online, and I've got the link in the description below. It is worth just emphasising the fact that this is from 36 experts from 12 countries, so it's a multinational guideline. However, there is very little evidence on the management and the correct pathophysiology even of the disease itself. And as such, take everything that's written in this guideline with a pinch of salt, because as new data comes out, we'll get a much better idea of what to do. So this is really just a state of play as it is, and the best practice that can be suggested at this point in time. As with most guidelines, they grade the recommendations, and in this particular guideline, they've done it fairly simply. They've either got strong recommendations, or best practice, or weak recommendations. And what you will find is that the vast majority of the recommendations that they make are weak recommendations. And that is a reflection of the paucity of research that's currently available on the optimum management of COVID-19 patients. As time goes on, we should hopefully have far more evidence, and after we get that, we'll be able to update and improve these initial guidelines. Having said that, the guidelines themselves form a fairly sensible structure to the management of most intensive care patients and doesn't really deviate from what we normally do for the vast majority of patients. And as such, I think it's quite useful because actually the people describing wild and wonderful different types of treatment and different ventilatory strategies that are way outside of what we would normally do for patients with severe respiratory failure, I take with a pinch of salt, because the things that are provided in this guideline are things that we know, we've got evidence for, and even if the pathophysiology might be slightly different, the underlying physiology of the body stays the same. So I think in general, the guidelines here are fairly sensible and robust. The first thing to say about COVID-19 is it's a very difficult disease to really understand. And we don't really even know how many patients are presenting with severe respiratory failure or even some respiratory failure requiring supplemental oxygenation. The best data that we have is from China, but we have to bear in mind that there was to date not been any population-wide screening of patients with coronavirus. And as such, we don't know how many of the patients who are presenting to hospital are a proportion of those that are actually exposed and infected with the virus. So the numbers that we see here are just from a few studies. And the studies that we have suggest that about 14% of patients with COVID-19 require oxygen therapy and 5% of those require intensive care admissions. Between 4 and 13% of these patients who come to hospital require non-invasive positive pressure ventilation, and between 2.5% and 12% require invasive ventilation of those coming into hospital. Now, we're starting to see that there are wide different presentations depending upon the socioeconomic group of the patient, but also the ethnicity of patients. And so until we see country-specific data, it's very difficult for us to really extrapolate this to the UK or other countries. There was an interesting observational study that was done that suggested that out of 52 critically ill patients in China, 67% of them developed the classical ARDS type picture with bilateral multifocal patchy consolidation with an increased oxygen requirement. About 63% required high flow oxygen at some point, and 56% of patients went on to invasive mechanical ventilation, with about 40% having a trial of non-invasive positive pressure ventilation. Obviously, some of the patients with non-invasive ventilation went on to mechanical ventilation. Similarly, some of those patients with high flow oxygen required in invasive mechanical ventilation. Interestingly, looking at these numbers, it looks like not every patient who developed classical ARDS went on to have invasive mechanical ventilation, and that may be a reflection of escalation limits being placed on a particular patient due to, for example, patient wishes, family wishes, and comorbidities. So the first of the recommendations when looking at the ventilatory support of patients is that of oxygen. And what they've suggested is to start supplemental oxygen when SATs are less than 92%. And actually, supplemental oxygen has been recommended at less than 90% in some countries. And for example, in the UK with the NICE guidelines on oxygen therapy, those are slightly different also. If you want to see those, there's a video on my channel which goes through those in detail, and also a few cautionary points about using these slightly lower oxygen saturation targets on the ward. But generally speaking, what we're seeing is that these patients have a slightly lower oxygen threshold at which to start supplemental oxygen. What's also interesting is the emphasis not to get SATs above 96%, and I think that's really important, not just in COVID, but in all patients. I think in general, we aim for very high saturations, 97, 98, 99, or even 100% saturations, at the risk of giving high fractional inspired concentrations of oxygen, and we know for a fact that high fractional inspired concentrations of oxygen increase oxidative stress in lung tissue and cause damage. We see that most acutely in young lungs, so in babies, but we also see that in adult lungs as well. So always be careful of hyperoxygenating patients. If patients' SATs are above 96, always be conscious to turn down the FiO2 if you can. This is a really interesting recommendation by the Surviving Sepsis Group. They are advocating for the use of high-flow nasal cannula oxygen. Anyone who's done intensive care in the last 10 years knows what a massive change high flow has been to the management of patients with ventilatory failure. And we've proliferated the use of this not just in intensive care, but also on the wards. In the COVID pandemic, there were specific guidelines early on to avoid high-flow nasal cannula oxygen. The thinking behind that was more to do with the fact that we were worried about aerosolizing the pathogen, and if we aerosolized the virus, we would expose multiple other patients and also healthcare workers to the virus. Having said that, there is data coming out from both Spain, Italy, China, and also now in the rest of the world as they're developing their own pandemic, their own infection groups, that high-flow nasal oxygen may be quite useful, and certainly intubation and ventilation confers quite a poor outcome for the majority of patients with COVID-19. That work in itself is still ongoing. But it's interesting to see that they have made a weak recommendation for starting with high-flow nasal oxygen, especially if they're failing conventional oxygen therapy, whereas in the UK at least, the initial guidelines were to have an early intubation. My personal feeling is if we can provide safe high-flow nasal oxygen, i.e. providing adequate personal protective equipment for everyone on the ward, that's other patients and also healthcare workers, maybe high-flow oxygen would be a useful second line to when supplemental normal oxygen therapy fails. You'll hear this quite a lot, but as it stands, there is no robust data on the use of high-flow nasal oxygen in COVID-19. There are lots of case reports coming out, but what we really need is a randomized controlled trial, which we lack at this point. There have been RCTs of high-flow nasal oxygen versus conventional oxygen therapy in other diseases and other viral infections, also pneumonias. And what they have shown is that there is a reduction in 90-day mortality, with quite a big drop in odds ratio of 0.42, with the confidence interval at 95% being between 0.21 and 0.85. So it is a significant drop in 90-day mortality. And a systematic review also showed that there was a reduction in the rates of intubation. Now, the studies are slightly variable. Some show that there's a reduction in intubations, others don't. But certainly from clinical practice, we've definitely seen patients' work of breathing drop significantly once they're on nasal high flow, and patients definitely tolerate nasal high flow a lot better than they do non-invasive ventilation with a tight face-fitting mask. What's really interesting is the SARS data for nasal high flow, and what they found was there was no actual increased risk of viral or bacterial transmission to healthcare workers when using nasal high flow. Vapotherm, one of the companies that make the humidified high flow nasal oxygen therapy units, actually did a study where they just put a simple surgical face mask over a patient wearing nasal high flow cannulae, and the aerosolization distance was no different to that of wearing just a standard oxygen mask. So the worry about the fact that it aerosolizes the virus may be there, it may not be, but we just don't have the robust data at the moment to prove it one way or the other. But interestingly, there is some indication that it may not be as dangerous as we once thought, and if it can stave off patients from being intubated, which we know, and we've got repeated data suggesting that intubation and mechanical invasive ventilation confer a bad outcome to these patients, and they often end up developing multi-organ failure. Now, the slight proviso to that is it might be that the poor outcome is because these patients are just more sick, and so they end up needing intubation and ventilation, and then they just develop their multi-organ failure as a natural progression of their specific disease process anyway. But certainly there's a lot of hemodynamic changes that occur with intubation and ventilation, and certainly positive pressure ventilation can be quite injurious to lung, increase inflammation, and potentially could increase the risks of developing acute kidney injury. What's also really interesting and counter to some of the evidence that we've seen in other countries is the recommendation to use high flow nasal cannula oxygen over NIPPV. I think that's interesting for a number of reasons. Firstly, there was a lot of Italian data where they used the big hoods with continuous positive airway pressure with the hood. And the benefit of that is that it minimized the aerosolization of the virus to the surrounding patients and also to the healthcare workers. Also, the nasal high flow uses up a huge amount of oxygen. At its highest flow, we're talking about roughly 60 litres per minute, which is much less than most ventilators and also just bedside CPAP machines. And part of the reason why we were avoiding using high flow nasal cannulae at the start of this pandemic was because of stories of hospitals almost running out of oxygen because of the massive increase in the oxygen demand on the system and the VIEs just emptying too quickly. But the reason they've made this recommendation is citing data from other disease processes where they have found that high flow nasal cannulae reduce the need for intubation compared to positive pressure ventilation. Part of that might be the fact that it's more efficient, there's less user and patient error involved with putting a patient onto nasal high flow as opposed to trying to put a well-fitted mask onto a patient who's already in respiratory distress. Secondly, patients find it far more tolerable to have the nasal high flow cannulae compared to trying to put a face mask on and then using relatively high pressures. Non-invasive ventilation in and of itself is a nuanced treatment, and it requires people who are very well versed in how to manage it and how to synchronize a patient with the ventilator in order to maximize the therapy. And very often it's junior people trying to put a non-invasive ventilation onto these patients, and as such there's probably a degree of treatment failure just purely due to iatrogenic errors. There is a question as to whether non-invasive ventilation might aerosolize the virus more, and it's definitely classed as an aerosolizing procedure. Part of that aerosolization risk might be from risks of disconnections or from leaks around the mask. It's one of the reasons why the Italians specifically were suggesting the use of the hoods early on, because there's much less chance of there being a leak around the shoulders than there would be around the face with an ill-fitting face mask. But it's interesting that they do suggest high flow over non-invasive ventilation. I cannot emphasize enough this point that they make. But I think they've sort of made it about just non-invasive ventilation, where they've said that we should be closely monitoring it. I think that the same should be the case for high-flow nasal oxygen. High-flow nasal oxygen, in my mind, is an advanced ventilatory support mechanism. Because what we're saying is that they're requiring supraphysiological levels of oxygen at supraphysiological deliveries to maintain a level of clinical stability. So the moment something goes wrong, things deteriorate quickly, and also you don't have much buffer between them deteriorating and requiring intubation and ventilation. So I think that not just with high flow oxygen, but also with NIPPV, you do need close monitoring. My personal practice is that if patients are being put onto non-invasive ventilation, then they're put into a level 2 area with at least 1 to 2 or 1 to 3 nursing care, because I think these patients can deteriorate very quickly. Interestingly, they made the specific point of not making a recommendation about the helmet non-invasive positive pressure masks as opposed to the simple face masks. The reason for that is a lack of experience amongst the group of people doing this guideline, and I must admit myself that I haven't got a lot of experience with the masks either, with the helmet either, so I couldn't comment either way. But I certainly have seen and spoken to many colleagues in other countries who have used the helmet and used it to quite good effect. Certainly patients find it a lot less distressing than having a face mask strapped to them. I think it's really important that anyone who has got COVID-19 who is requiring non-invasive positive pressure ventilation or high flow nasal cannulae, you have to be cognizant of the fact that they can deteriorate and deteriorate quickly. I have certainly had a number of patients who have come in not on any oxygen and then within a few hours ended up intubated, ventilated with multifocal consolidation on their chest radiograph. So these patients can deteriorate quickly, and the only way we can pick them up is by monitoring them closely. And so that, by almost definition, means they should be in a level 2 or a level 3 area. Looking specifically at non-invasive positive pressure ventilation, there's a little bit of data with regard to the MERS population. So there's the Middle Eastern Respiratory Distress Syndrome that was a few years ago now. But still, we are getting cases elsewhere in the world. What they did show was that non-invasive positive pressure ventilation had no improvement in length of stay or in mortality, and had a massive failure rate, 92%. And if patients had NIPPV before they were intubated, they had a much higher mortality. There were lots of questions as to why that might be, but certainly one logical conclusion could be that patients who should have been intubated had their physiological demands reduced earlier with intubation, ventilation and sedation were not, and also their sputum clearance was just that much poorer because they had a mask stuck to them, that they deteriorated very quickly. So based on just purely the MERS data, the use of positive pressure non-invasively, we've got to do with a little bit of care. Having said that, like I mentioned, helmet CPAP seems to reduce intubation rates in other countries, and I think until we get a bit more data out, it would be interesting to look at, but certainly something to bear in mind. It seems to improve mortality, and whether that's partly because we're staving off intubation, which we know the intubated population of patients do very badly in intensive care, with almost a 65% mortality in the UK ICNARC data. And with using helmet CPAP hoods, we may well be able to reduce the amount of environmental spread and contamination. Having said that, I haven't to date seen any data on COVID-19 spreading and sort of aerosolization of the virus whilst in a helmet, but conceptually at least it seems like it would reduce the amount of aerosolized virus. The guidelines themselves provide quite a nice algorithm and something just to think about as we go through a patient who is presented on the wards or in A&E with hypoxia. The first thing to do is to notice that the patient has got hypoxia, so SATs of less than 92 or 90%. And then think early about whether they need endotracheal intubation. This is really important and probably quite different to the way in which we've approached patients with respiratory failure on the wards in the past before COVID-19. Before COVID-19, we would often jump straight to giving supplemental oxygen. But here, there should be a pause. Should they be intubated? If they do need to be intubated, then endotracheal intubation with an expert to do the airway, and the people who are intubating should have all the appropriate personal protective equipment. That's all outlined in other videos of mine. And what they've suggested is using a video laryngoscope, and I mentioned that in the first of the talks about the Surviving Sepsis guidelines, where we talk about infection control in these patients. If they don't need endotracheal intubation immediately and they're tolerating supplemental oxygen, then essentially what we're trying to do is just to monitor these patients, and the key thing here is to monitor them closely and not to delay intubation if the patient is deteriorating. If they don't seem to be tolerating the supplemental oxygen, i.e. they're not targeting the saturations of 90 or 92%, then what they've suggested here is to consider high-flow nasal oxygen. I would say that that's appropriate if everyone else on the ward, healthcare worker-wise, has got level 3 PPE on board. And also we've cohorted patients who have just got COVID into that area. Ideally, it should be done probably in a negative pressure area, and if not that, then maybe thinking about those HEPA filters that are portable, which again, go to my first video in this series where we talk a little bit about that. If they don't tolerate high-flow nasal oxygen, they do say to consider non-invasive positive pressure ventilation and to intubate if they worsen. Personally, I think that if they don't tolerate high-flow nasal oxygen, my threshold for intubating would be quite low based on the MERS data on how, if we delay intubation too much, these patients have a much higher mortality and morbidity. The guidelines then move on to talking about the invasive ventilatory strategy for these patients. And there's been a lot of debate about low PEEPs, high PEEPs, and we'll go through the main recommendations here and then talk a little bit about what the potential pros and cons of it are. As a general rule, throughout these guidelines, essentially what they are advocating for is good ventilatory strategy that we would do for any other intensive care patient. These guidelines are not advocating for anything new or anything different to what most people would do following the ARDS-NET protocols. So the first of those things is to use a low tidal volume. So 4 to 8 ml per kilo. And that's a strong recommendation, and to be honest, I can't think of many intensivists who wouldn't use this. They actually give quite a useful summary of the data and also then just some practical considerations. And what they've suggested here is to set an initial 6 ml per kilo. And I'd say probably in 99% of patients, that's probably where I start anyway with patients, and then work up or down depending upon the CO2 and the driving pressures. What's really interesting is that they say here to increase to 8 ml per kilo if the patient's double triggering or if the inspiratory airway pressure decreases below PEEP. I'm not sure I'd agree with that completely. I'd see why they say that. However, if patients are dropping below their PEEP, the real true risk of that is that these patients can get atelected trauma of their alveoli. And so I think there's a number of different things that you need to do there. And ventilatory strategy in that sense is not just a matter of changing the numbers on the ventilator, but also thinking about sedation, thinking about whether we should be paralysing these patients, thinking about what the optimum PEEP is, and thinking about the different types of ventilatory strategy. And certainly if I'm seeing patients' breaths going below their PEEP, I would have quite a low threshold to putting these patients onto APRV. Now you have to look at their own individual respiratory dynamics and thinking about whether we're over-distending alveoli. So there's a little bit of bedside management of these patients that needs to be done. But certainly if you're seeing the inspiratory airway pressures dropping below the PEEP levels, then you do have to be careful, and it's something that's really worth looking at. And you'll be surprised how often when you walk onto a unit, patients are dipping well below their PEEP setting and no one's changed anything about it. I think the target tidal volumes in spontaneously breathing patients with COVID has been really difficult, and I've seen patients drawing in massive tidal volumes. And for me, my real worry with that is the massive transpleural pressures and the big risk of atelected trauma. As such, there have been some cases where I've very heavily sedated the patients and even gone to the point of paralysing them just to get them over the initial period of ventilatory failure till we get stability. So even up to 48 hours of paralysis just to make sure we stabilise the patient. Because I very strongly believe, now there's no evidence for this yet, but I really truly strongly believe that a lot of the damage that's done to the lungs in the first 48 hours is down to us intubating, ventilating these patients, and then giving them inappropriate tidal volumes and inappropriate pressure differentials and transpleural pressures, and so effectively damaging their fragile alveoli. And that might be an explanation as to why, in part, patients do much better when we don't invasively ventilate them. As with the ARDS-NET protocols and many other studies, keeping a plateau pressure of less than 30 is important, and I'd agree with that. They do provide this useful summary of the recommendations, which it's worth just taking a little bit of time to think about. I think here, what we talked about with the 4 to 8 ml per kilo and a plateau pressure less than 30, what they don't talk about in this is driving pressures, and I do think that having a driving pressure of less than 15 is important. And that's not just for alveolar overdistension, but also for atelected trauma. I think I cannot emphasize enough how important it is to look for other diagnoses. Now, I have a suspicion that COVID-19 is actually out in the population, and a lot of patients have asymptomatic disease, and they may be presenting with a completely different disease, and that can include bacterial pneumonias. So it is worth sending off the sputum and the blood cultures and so on to look for that. Fluid strategy is really difficult, and we'll talk about this a little later. But if you look at the hemodynamics lecture, the one before this, we do talk a little bit about the fact that we should be thinking about intravascular volumes. My talks on the L and the H phenotype of COVID-19, check out those videos, do talk a little bit more about this. And there is a suspicion that actually we might be over-PEEPing these patients with the L phenotype, and we might be actually drying them out a bit too much. And one thing we've certainly seen time and time again with these patients is that they are hypercoagulable. So even though it says here a conservative fluid strategy, I think clinical euvolemia and using whatever investigations you have, achieving euvolemia is probably the most important thing. I think as intensivists we often end up being quite good at thinking about starting antibiotics. What we have to be good at is actually just not giving antibiotics where it's not needed. And certainly there's a lot of fungal infections that have started to come up in patients who are recovering from COVID-19, and some of that is probably related to the antibiotic use and the wiping out of the normal flora, allowing for fungus to grow. So I think procalcitonin is a really useful guide, and certainly what we're seeing is high CRPs in COVID patients, but with very low procalcitonins. And then as the procalcitonin starts to increase, then usually that same day or the next couple of days, we start to see manifestations of a bacterial superadded infection. So procalcitonin is really useful. In patients with moderate and severe ARDS, it is worth considering higher PEEPs. These patients are probably easier to think of as the classical ARDS type patient, and they fall into this so-called H phenotype. Again, go back and watch my video on the H phenotype of COVID to get a lot more information on it. But things to think about are neuromuscular blocking, and that's useful not just for ventilator synchrony, but also to try and drop your driving pressures and your plateau pressures. Recruitment maneuvers. So there is a move against using stepwise recruitment and just giving a big PEEP. Personally, my practice is to use APRV as my recruitment maneuver, and I've got quite a lot of experience in using APRV, so I'm quite happy doing it. But in units where APRV might not be an available option on your ventilator, or if you're not happy with doing it, then just a traditional recruitment maneuver is helpful sometimes in these patients. And looking for the inflection points is also useful when doing those recruitment maneuvers. Proning has been proved to be really helpful in patients, and certainly I've seen dramatic changes in patients where we prone them for 12 to 16 hours. The problem is a lot of these patients you can't keep proning because they can get other injuries, say for example to the eyes, facial plethora, and difficulty with nursing care. For those patients, what I sometimes do is actually take a filter 4-litre bag of fluid and put it on the chest. It doesn't replicate all of the physiological changes that we use in proning a patient, but it can help. And especially if they've got some airways disease with it, it can help with passive expiration as well. They do suggest the use of systemic steroids, although it's a consideration, and we'll talk a little bit about that a little later when we talk in the next talk about COVID-specific treatments, and think a little bit about the cytokine storm and this so-called HLH type presentation that some patients are coming with. In terms of rescue and adjuvant therapies, there's a few things like antivirals, chloroquine, anti-IL-6, which again we'll talk about in the next talk. They do suggest the consideration of nitric oxide, and I think nitric oxide is useful and certainly something that I've used on a number of patients. However, it's got to be done in the right way and have a good understanding not just of the procedure of doing it and of the equipment, but also an understanding of how to wean it off, because you can get quite nasty rebound pulmonary hypertension with these when you come off nitric oxide. And of course, the rescue if all ventilation fails is a referral for VV ECMO, and that could be done at your centre if you do it, or at another centre. But have a think about doing those calls early, because certainly the criteria for ECMO are fairly stringent, and if patients have been on a ventilator for weeks and weeks, then the chances of them taking the patient is low, because they would have already developed fibroproliferative ARDS, and there will be less recoverable lung, and there'll be less reversible lung injury there. There's been a lot of debate about using low and high PEEP strategies depending upon the type of patient you've got, whether it's an L phenotype or an H phenotype. I think it's probably overcomplicating matters, and I think we treat these patients like we would any other patient. We don't give massive PEEPs and over-distend alveoli, but at the same time we don't use very low PEEPs. I think we can't just give a standard therapy for every patient, but I think a PEEP of around 10 is appropriate for most patients. We might need less in some, but for most patients 10 is appropriate. The worry was that we were over-distending patients or causing acute kidney injury and reducing venous return into the right side of the heart and dropping cardiac output and so on. But the honest truth is I don't think that's necessarily as big an issue as understanding the underlying disease itself. And one thing we certainly do know is that atelectasis trauma is very bad for patients. And like I said before, I do feel like some of the disease that we're seeing with the lung inflammation is actually iatrogenic, and it's from poor ventilatory strategies. We've got quite good evidence now that giving adequate amounts of PEEP to patients does reduce both their morbidity and their mortality. So I think we have to go with what we know. Again, this conservative fluid strategy over liberal, obviously there's a lot of data suggesting that giving too much fluid to patients is bad, but at the same time we do need to give enough fluid to make sure that the patients are clinically and intravascularly euvolemic, and that's so important. And so whatever adjuncts you can use to do that, whether that's a cardiac output monitoring, clinical examination, TOEs, transthoracic echoes, whatever it is, it's worth using those to try and make sure that your patient is completely euvolemic. For moderate to severe ARDS, they've suggested proning patients for between 12 and 16 hours. Now, I would take slight issue at that, and there has been good evidence that self-proning of patients before they've even been intubated may stave off intubation. And as such, I think a lot of patients, if they're requiring high oxygen levels, and in my mind I have a level of above 60%, I would be proning those patients. There's a lot of physiological benefits to proning. It's difficult, it's got its side effects and problems, but if done well, it can massively improve respiratory dynamics and even cardiovascular dynamics, and may prevent secondary lung injury from our ventilatory strategies. In patients with moderate to severe ARDS, there's also a suggestion that we should be considering neuromuscular blocking, and what they've suggested is either continuous as an infusion or intermittent. I think for most of us we use continuous neuromuscular blocking, especially if we've proned the patient, as much from a practical perspective to stop them from coughing the tube out, and also to try and prevent those ventilator dysynchronies, which certainly it seems that in COVID they have a very high neural drive for whatever reason, and there's a huge amount of research looking into whether the coronavirus itself is affecting parts of the brain and parts of the respiratory centres that are causing this big air hunger and this large ventilatory drive that we don't really see as much in other conditions. They do recommend against routine use of inhaled nitric oxide. I think that's absolutely right. Not only would it be impossible to instigate in a large number of patients, but also I think there's a lot of nuance to using inhaled nitric oxide and knowing what dose to escalate up to. Do you start straight at 20 parts per million, or do you titrate? How do you get them off it? Do you come stepwise off with a couple of parts per million every 2 or 3 hours? What's their right ventricular function like? There's a huge amount of consideration that needs to be taken when starting a patient and taking them off nitric oxide. But no doubt, in some patients it really does work. And improving your VQ matching is probably the way in which it's doing it. Probably also partly offloading some of the right ventricular strain as well in patients with significant pulmonary hypertension, whether that's relating to pulmonary emboli or whether it's related to the inflammatory state that the lungs are in. And I do like the fact that they do emphasise the fact that it should be tapered off, because you can get rebound hypertensions, less so with the inhaled prostacyclins, but certainly with inhaled nitric oxide. So it is worth, if you're going to do it, to be experienced in using it and weaning it off. They do suggest the use of recruitment manoeuvres, and like I say, the way in which I instigate that practically is by using APRV. And they recommend against using incremental increases in PEEP for the recruitment manoeuvre. And speaking to most people, I don't know of many people who still do incremental PEEP manoeuvres. Most will do a standard PEEP increase for recruitment. Then obviously those patients who are failing all conventional strategies and all the different techniques that we've used, VV ECMO is the next step. And my only comment with that is to make sure that you make those referrals early, not least because of resources, but also you can get patients to a point where you've caused so much damage from mechanical ventilation that they're just not suitable candidates for VV ECMO. So in summary, there's a lot of information there. It's really interesting that they talk about the role of high-flow nasal cannula oxygen. I think it's a great therapy, but it needs to be done in the right place with the right protection of healthcare workers. Helmet CPAP may have a place in the management of patients, but honestly, I don't have enough experience with it, and I haven't seen enough data to really be able to say one way or the other, and the guidelines themselves sit on the fence. The general ventilatory strategy for these patients is basically what we do with every other patient. Low tidal volumes, keep the plateau pressure down. Although they don't mention driving pressures, I have put it in there because I think it is important that we keep those driving pressures below 15, maximum 20. I think the lowest FiO2 possible is important to reduce the oxidative load on the lungs, and whether you use a high or a low PEEP I think is relative. The worst thing that you can do is use too low a PEEP, because we will cause atelector trauma. So always, if you need to, err on the side of higher PEEPs, and I think 10 is a good sort of baseline for most people to start off at. Prone patients, don't be afraid to prone them. They seem to do very well with it. And use neuromuscular blocking agents, and avoid routine use of inhaled nitric oxide. Certainly for some patients it works beautifully, but if it is to be used, it needs to be done in the hands of people who are experienced with it and understand the nuances of how to start it and how to stop it. In the next part, I'll go through the final bit of the guidelines, which is really interesting because they go through some of the evidence for the COVID-19 specific treatments that are available. And as such, we'll have a little think about the evidence for it and what things we should be doing and what things maybe we shouldn't be doing. So I'll see you for the next video. Thank you very much.